Hi, everyone. This is Rajiv Ramchand. This is session 5 of our basic epidemiology series. I'm providing this information, basic epidemiologic concepts, to help my family, friends, and the community at large really just better understand the news that's coming towards you with respect to the COVID-19 virus and pandemic. So let's get started. Today, I really wanted to talk to you about our surveillance systems in the United States. I think it's become really important to focus on these concepts these days. So this is something that I actually didn't study in graduate school and had to spend kind of a weekend learning. And basically, when we're talking about disease surveillance, we're talking about an ongoing process that involves systematic data collection, analysis, interpretation, and dissemination of information regarding diseases. And our goal of doing this is to ultimately reduce the morbidity and mortality associated with those diseases. So sickness and death, essentially resulting from those diseases. So these are called different things. The way that I've kind of distilled the information is that there's basically 5 core surveillance kind of actions that happen within communities, within the country. And the first is vital statistics. It's where we begin and end, our births and our deaths, but it also includes data on marriages and divorces. Examples of why we would use that is to see whether there are changes in birth weights of kids or causes or the mechanisms of death, whether we can kind of get indications of that over time. Syndromic surveillance involves identifying disease symptoms prior to a confirmed diagnosis. So for example, we might see sudden increases or detect via surveillance sudden increases in respiratory or digestive systems in emergency departments in a certain region that are cause for concern. So we don't yet know the pathogen or the agent that's causing it. We just know that there is a lot of kids coming in, for example, with upset stomachs, and we want to make sure that we're on top of that while we wait for an official confirmed diagnosis. Disease surveillance or case surveillance is once we have that confirmed diagnosis. So for example, confirmed cases of COVID-19 would be a case surveillance. Laboratory surveillance, that's looking at the pathogens among people who are ill. So we can see whether the virus is kind of staying the same in its kind of chemical and virologic composition, or whether it's going through any types of changes, any antigenic shifts or drifts, because that will really be informative as we think about disease spread, and especially as we think about the development of our vaccines to target the disease. And then finally, there are lots of surveys out there that are part of our surveillance system, and usually we use those to measure the conditions that may not show up in our healthcare systems. So for example, changes in population cigarette smoking, the proportion of the population that's vaccinated, that's information that will derive primarily from our surveys. I'm not going to go through all of those. What I really think is important to talk about disease or case surveillance in the USA, as well as syndromic surveillance, because I think that's really interesting. So with disease surveillance, the system is the NNDSS. So a person feels ill and goes to the doctor. The doctor conducts some laboratory tests and diagnoses the disease. And then depending on where that doctor is located or that healthcare facility is located, they're required by state law to tell the local and state public health officials reportable diseases that are defined by the state or local health department. So that's a mandate. Then the local health department or the state health department provide data on a set of diseases to the Centers for Disease Control or the federal government. So we get national estimates. That latter part is a voluntary submission of data. So the states voluntarily submit that data to the CDC. Each year they come up with the disease states that are going to be what they call notifiable diseases. And in 2020, there are 120 notifiable diseases that were come up with between local health departments, the CDC, the state health departments, and those 120 diseases then get tracked across the country. As I said, it's a voluntary process. Right now, 57 health departments are providing that data on those 120 diseases to the CDC. All US state health departments, 5 territorial departments, New York City and Washington, DC. Syndromic surveillance in the US, a person feels ill and goes to the emergency department or urgent care facility. they're the ones who then provide that data to the local health department. And data is provided on the chief complaints, the diagnosis code, characteristics of the patient, and where they are located. And that all goes to the local health department. And then it gets uploaded to this cloud maintained by the CDC and a collaboration, really a public-private collaboration. And that data can be analyzed almost in real time to really detect the emergence of new diseases and how new, or not diseases, I guess, new symptoms, and how those are potentially clusters of diseases within urgent care facilities or emergency departments. And according to the CDC's website, the system, the NSSP system that tracks syndromic surveillance, currently covers around 71% of emergency departments in the country. There's also tons of surveys, and honestly, this is where the bulk of my own personal research occurs. I administer surveys as well as analyze data from these surveys, and I've just listed a few of them here. So we have the National Health Interview Survey, the National Immunization Survey, National Survey on Drug Use and Health to get estimates of drug use and mental health conditions, the Behavioral Risk Factor Surveillance Survey. You could read these all, but there is a ton and many more that I've included that are really trying to get different aspects of our nation's health that may not present itself to healthcare facilities. And so we rely on people kind of telling us this information. I really wanted to understand better how our national surveillance system for COVID-19 is operating. And what the information I found from the website, from this website down here, pointed me to a speech that was given that said that our COVID-19 surveillance system is built upon this voluntary influenza surveillance system that's a combination of a lot of the things that I already mentioned. So we have virological surveillance for flu that's happening in 400 laboratories across the US that already have a connection, and they're testing respiratory samples for flu and now for COVID-19. We have virological surveillance that's usually in the local public health laboratories that's looking at characteristics of the virus itself, as opposed to the initial virologic surveillance that's happening at the laboratories, that's just the presence of the virus. The second is that more in-depth one that I was talking about, looking at that antigenic shift or drift. Then we have, it seems to me, 3 different types of case surveillance. Novel influenza A is a nationally notifiable condition, which one of that group of 120 that we already discussed. Because a lot of people will get a physician will say, or a healthcare facility will say that they likely had the flu, but they won't actually do a laboratory test for flu. Because that can exist, we have a network of outpatient health facilities that are providing data on a weekly basis to the government about the number of cases of likely influenza-like illness that they've seen, as well as the patient age. And then for confirmed flu cases that are hospitalized, we have a small network of hospitals within states that are providing information about influenza-related hospitalization. So we have the outpatient, we have the hospital, and then we have this notifiable condition of influenza A. And then we're also using data from vital statistics. Unfortunately, we're looking at death data here. So we're looking at both deaths caused by influenza, as well as at the federal level, pediatric mortality from influenza is a nationally notifiable condition. So it seems to me as if this is the system in which our COVID-19 surveillance is currently based on my review of the websites and the literature and the speeches. But this is so novel that it's such a new kind of occurrence that forgive me if it's inaccurate in any way. And if it is inaccurate and you know that, please let me know. What I found really interesting is that our surveillance in the midst of this COVID-19, there's a lot of private entities, non-governmental entities that are providing surveillance data. So one of the ones that I've been using is this covidtracking.com, the COVID Tracking Project, and that is providing information, especially on negative test results at the state level on an almost daily basis, and they're assigning a quality grade to the data so that you can take into consideration when you look at the data. We've seen the emergence of Johns Hopkins was really at the forefront of providing geo-mapped data and surveillance data on COVID-19. The New York Times has an excellent map that they've produced. Those are just 3 examples. I'm not advocating any of them, and I haven't been sponsored, but those are some of the surveillance mechanisms that I've seen emerge from private entities that are really kind of informative, and they've really stepped up. I really just want to identify this notion of contract tracing because it's come up, especially with respect to COVID-19. What it is, and this is according to the World Health Organization, it's identifying and following up with persons who may have come into contact with a known infected person. So essentially what you do is you interview a case, somebody that you know is infected, and have them walk through kind of their routines from when they likely became infected to the present. You list out all of the people through those activities that they likely came into contact with. And then you follow up and say, we have the reason to believe that you were in contact with so-and-so who recently tested positive for this infection, and we think you should be tested as well. We've seen contract tracing already happen with respect to COVID-19. These are quotes from an article in NPR, and you'll see that South Korea, Hong Kong, and Singapore have used contract tracing in different ways. But all of them, instead of relying on kind of that, what I just described, which is kind of old school contract tracing, which is really making use of mobile technology and geomapping technology. So South Korea used data from surveillance cameras, cell phones, and credit card transactions. Hong Kong released detailed information about each new confirmed case, including the location of where the person potentially worked, also taxi drivers, the license plates of taxi drivers who tested positive, as well as flight numbers of people who recently arrived who tested positive. So a lot of this stuff was happening, maybe at a more population level, but this is kind of what I would consider kind of within the realm of contract tracing. And of course, this then leads into a lot of controversy that we've heard about because some of these countries have actually experienced much less disruption due to COVID-19, some of which may be attributable to COVID-19. I'm just speculating or hypothesizing. But of course, a lot of these procedures raise a lot of concerns, especially privacy concerns in the United States that would need to be into consideration. And there you have kind of public health, and we have to think about the ethics and what we're doing for the public good and make sure it's not violating our ethical kind of standards. And finally, I just wanted to end, we're going through all this, and never has it been more important to me to think about the denominator. Our population estimates are so important. Right now, we're in the middle of collecting data for the 2020 census. You all have probably received your cards. For those of you who filled out the census, thank you for doing it. It's such crucial and important information. For those of you who have yet to do so, please, please do so. It really helps us estimate the burden of disease, especially looking at rates of disease. And all of our surveillance systems in terms of rates are based upon the information you provide on the census. So it's so, so, so important to fill it out. And for those who are so inclined, I would really recommend going to data.census.gov and playing around with the data. You can find out so much information about population characteristics, about the country, about your state, about your community. It's really just a fun tool to play with. They've revamped it recently. It's really easy to use. You don't have to be an epidemiologist. So I'd really encourage you to start exploring the data. I know you have time on your hands these days. So take a break from Netflix, go to data.census.gov. That's the end of this session. We're going to be talking about outbreaks and how we go about investigating outbreaks. Until then, stay safe, stay healthy, and stay informed. Thanks.